Tonight, without any further ado, I have the pleasure of introducing you to Dr. Patricia Chang. Dr. Chang earned her Doctor of Medicine from UCLA in 1996 and was board certified in internal medicine in 1999. Let me give you a little known fact about her chosen profession. Prostate cancer is the second leading cause of cancer deaths in men in America today. And yet there are slightly less than 50 prostate cancer specialists in the whole United States. We're lucky enough to have 3 of the best right here in Southern California. I'm sure that most of you have heard of the prestigious doctors at the prostate oncology specialists in Marina del Rey. Dr. Mark Schultz, Dr. Richard Lamb, and now the newest addition to their team, Dr. Patricia Chang. I've personally been a patient at the prostate oncology team since 2005. I've been switching back and forth from Dr. Schultz to Dr. Lamb, depending on their availability. Dr. Lamb often joked that they were the Batman and Robin of the prostate oncology world. Although each had a slightly different approach, my personal feeling that I was in the hands of the best of the best. A couple of years ago, Dr. Schultz confided in me that with the growth of their practice, he would soon need a new associate. I know personally that he consulted with several prestigious doctors before making his decision. I was apprehensive agreeing to see this new addition to the team, as I was already seeing the best. I found, however, that after meeting Dr. Chang, she added another whole new, very caring, knowledgeable, and professional approach to the new team. Batman and Robin now have their own Catwoman. Dr. Chang tonight will talk about the side effects of hormone blockade, including fatigue, cardiac and vascular disease, lung disorders, sleep apnea, thyroid disease, and diabetes. She will also address the roles of nutrition and overall health as they relate to prostate cancer. It is with great pleasure that the Prostate Forum of Orange County presents to you Dr. Patricia Chang.
I did leave my Catwoman cape at home, so I'll bring that next time. I'm Patricia Chang, and I thank you for asking me to speak. It's a real privilege and an honor. The first question I always get is, why did you choose this field as a woman? And the answer was simple. Dr. Mark Schultz, who would not work with one of the leading oncologists in prostate cancer, one of the most innovative practitioners now, and I get Dr. Lamb. So, put a fork in me, I'm done. My background is basically California, born and raised, Los Angeles. Did my training at UCLA in a 7-year combined pre-med program. Residency training in Long Beach, a UCLA affiliated program. And then work as a primary care doctor in various parts of Los Angeles, as both a primary care doctor and as a hospitalist for the indigent population of Long Beach for about 2 years. And then finally my own private practice where I could practice medicine the way I wanted to practice over the last 12 years. And then approximately 2 years ago, Dr. Schultz approached me and asked me to join. So it's a real privilege. This topic is vast and varied, and but more importantly, my real message is to empower all of you to be able to understand your health, take it in your own control so that you can understand how the decisions are being made and you can make those decisions. We as doctors are, how I put it, you guys are the CEOs and we are just your pushy business managers. And that really is the case. You ultimately dictate your own care. So, we're going to start with men's health and do an overview about prostate cancer itself. In the last 20 years, prostate cancer has decreased 40%, but our population is getting older, which is amazing statistics. And the reasons are, and I think one of the main reasons are early detection and treatment. Traditionally, we've had bone scans, technetium-99 bone scans and CAT scans. Now, with innovations including 3T MRI, prostate ultrasounds with vascular screening, vascular flow, and the newer scans, the carbon-11 acetate scan, which can look at a normal-sized lymph node and tell us if it has cancer or not. All these techniques are rapidly being developed and are expanding in different locations across the country. Earlier use of hormone blockade as well, and ultimately better hormone blockade. Right now we are using quite a bit of Zytiga. I don't know if any of you heard of Zytiga. Traditional hormone blockade has included Lupron, androgen blockers like Casodex, and nilutamide, and Avodart, which is an DHT blocker, the transition from testosterone to DHT. Zytiga is a newer kind of medication that stops the production of testosterone from the adrenal glands, but also stops the actual development of testosterone within the cancer cells themselves. I think one of the most exciting new drugs that we're very happy about is MDV-3100. Androgen receptor blockers are, such as Casodex and Lupron, are actually receptor agonists and antagonists. Many of us don't know that. We think it's just a pure blocker. But it actually has a component that stimulates the cancer cells also. MDV-3100 is a pure androgen blocker, and in the early studies of blinded, controlled versus placebo patients, the results were so great that they unblinded the study early and put all the patients on it. So this is a really good, exciting oral agent. And then our routine agents are, that we use include Taxotere, which is a tyrosine kinase inhibitor. Its nicer looking brother, Jevtana. Provenge, which is the vaccine that I hope you all are aware of. And the newest chemotherapy, which we just started using at Prostate Oncology, XL184, which basically stops the growth factor and stops a gene called MET, which actually is seen specifically in bone. And so when the cells stop growing, they produce more MET. This drug blocks both the production and the growth of MET. And finally, Kirsterson, which I think is an amazing drug. This one works along with Taxotere to prevent Taxotere's expulsion from the cancer cell. So it keeps the chemotherapy within the cell. So, what's our 10-year survival? Pretty good. Low-risk patients, which are Gleason 6 and under, 100% 10-year survival. Intermediate grade patients, Gleason 7, lower percentage of positive cores, lower percentage of the cores that are positive, a lower percentage of positivity. With treatment, which is hormone blockade, surgery, radiation, 98% 10-year survival. And even with high-risk patients who have surgery or choose no treatment at all, you have a 90 to 85% survival. Combination therapy, which includes surgery, radiation, hormone blockade, Taxotere, also 95% survival. With lymph node disease and early hormone blockade, you'll still have an 87% survival, and late hormone blockade 60%. So those are great statistics. So what do we die from? 350,000 patients die of vascular disease alone. You hear that mantra, you probably won't die of prostate cancer, it'll be something else. That something else is usually the vascular disease. Cancers, of the cancers, 90,000, 1/3 of the amount of vascular deaths are patients, cancer-wise, will die, 90%, 90,000. Prostate cancer, 30,000 patients per year. colon 20,000, and that's probably with more colonoscopies and better screening. And finally, infections, flu and pneumonia. What are your 5-year cancer survival rates? Lung cancer, 16%, 5-year survival rate. Prostate cancer, 5-year survival rate, 99%. So what does this cancer do? It gets you to me sooner. Most men don't go to the doctor. Women, we know we need to get our pap smears and our mammograms. Men don't really have anything that really propels us. This does. And what it does is it raises your own health awareness. Most of my prostate cancer patients are much healthier than the average population. Not only does it raise health awareness, but it starts a dialogue about quality of life. What are we doing now to change not necessarily our mortality, but more importantly, our quality of life? We also talk about what the side effects of hormone blockade may be, and are those side effects worth the actual treatment. And finally, risk management for other diseases. So atherosclerosis is one of the largest words and one of the hardest words to pronounce. Basically what it means is schmutz in the arteries. It's plaque and calcium that develops in the arteries. That plaque causes rupture, strokes, occlusions, blockage. And when we talk about cholesterol, which is the mainstay of plaque, we talk about good cholesterol, which is your HDL, or happy DLs is how I remember it, and the LDLs, which is the loser DLs. Our HDLs, ideally, greater than 50, if you're lucky. Greater than 40 is great. Bad cholesterol, we want less than 100, and ideally less than 70. And those numbers keep changing as we get smarter and smarter. Finally, this slide says triglycerides are less important. I disagree. Triglycerides are the fats converted from carbohydrates. If your levels are above 150 and above 200, you have to start thinking about glucose intolerance, possibility of diabetes. Triglycerides and diabetes cause small vascular disease, which, and where are the small vessels? In the brain, the penis, the feet, the heart. Total cholesterol, less than 200, who cares? Doesn't really matter, not a big factor. Look at these absolute values here. That's the most important. Of the 1.5 million heart attacks each year, half of those patients roughly didn't know they had heart disease. 62% of patients, their first time they figure out they have heart disease is when they have a heart attack. For men. For women, it's 46%, and that may be because they're doing more health screening, health maintenance. So what are our usual risk factors for vascular disease? The routine, family history. And when we say family history, that is anyone in your family under age 50, whether they've smoked or not, who've had early strokes, heart attacks, and arrhythmias. Diabetes mellitus. And I want to talk a little bit about diabetes because I think this is also an underexplored disease. We have a test called hemoglobin A1C, which is used to screen for diabetes, and that's an average of your blood sugars for over 4 to 6 months. You can imagine if your sugars are low and then periodically high, you're going to have a normal hemoglobin A1C. The gold standard for diabetes is an oral glucose tolerance test. And so at Prostate Oncology, we do pretty extensive lab work, and most patients aren't fasting. But if you find a level that is non-fasting, that is above 140, let that kind of be a clue to you. That may be something to explore. Risk factors, again, elevated LDL, low HDL, meaning less than 40, and actually I think that if you have a low HDL, your vascular risks are even higher than having a higher LDL. Tobacco, which is any kind of smoking, any history of smoking. So many patients I ask, do you smoke? And they say no. Have you smoked? Yes. Do you classify as your smoker? No. Any exposure is going to increase your risk. Hypertension, that's a big one too. Patients come in and they have white coat hypertension. They have high blood pressure in the office. Is it real? Is it not real? Well, ideally, your pressure should be less than 130 over 85. If your blood pressure is elevated in the office, that is a clue that when you are stressed, your pressures may actually be running a little higher than they should. Check your pressures at home. And also, I'll go into some vascular screening, some other clues that might tell you if you do have some underlying blood pressure issues. And finally, obesity and physical inactivity. So, most obvious reduction is dietary changes, weight loss. Fat, cholesterol, but also total calories. Do you know that 1 pound of fat is 3,500 calories? 3,500 calories, if you drop 100 calories a day, over a year, you'll lose 10 pounds. 100 calories is a piece of bread, an apple, half a glass of orange juice. Not such great changes. 200 calories, 20 pounds. So fairly simple, not so drastic. Regular physical activity, which includes greater than 3 hours a week of cardiovascular activity, that's breaking a sweat, getting your heart rate up. Smoking cessation and prevention. Aspirin, which we know not only reduces vascular disease, but probably also has some anti-cancer effects. We don't know if it's an 81 milligram or 325 milligram aspirin. We just know that is a benefit. And then traditional cardiac medicines. So what are those primary prevention tools and cardiac medications? Number one, aspirin therapy. Before I keep going, this will show you that you can reduce your risk by 100%. So 30% reduction by antiplatelet therapy, 30% reduction by blood pressure reduction, and 30% reduction by cholesterol therapy. Not necessarily statins, but statins are usually our routine mainstay. Now statins, I think, get a lot of bad press. Patients get started on Lipitor, they get started on Crestor, Zocor, they have leg pain, they stop. They say that's the cause, I can't take a statin. Usually muscle problems, liver problems happen, I would say, less than 1% of the time. If you have pain and you're not sure if it's your statin, I would ask you not to stop your statin, to go into your doctor's office and get a muscle test called a CPK. It's a simple blood test. If that is negative, it's probably not your statin. Let's see. So the challenge of diagnosing heart disease is finding a really inexpensive, simple, non-invasive test in people who have high cholesterol. One of the mainstays now also is cardiac CT scanning. Short, quick CT scan, very limited radiation, instant results. Diagnostic sensitivity. So what kind of cardiac tests can we run? Most people get a stress echo, which is about $300. It looks at depolarization of the muscle when you're exercising. Not so sensitive. You've got to have up to 70% of a blockage before this one determines anything. Stress echo also, stress thallium. These are the mainstays, nuclear stress test. Stress thallium, $1,600, and still won't diagnose any disease until you've got greater than 60% plaque. Coronary angiogram CT, right here, $300, same cost as stress EKG. It can detect as little as 20% occlusion. This is what it looks like. Normal, severe calcification, and in an asymptomatic man. This is almost 90% occlusion. So, calcification, what does it mean? Atherosclerosis. Higher coronary calcium scores correlate with higher risk. But more importantly, if you've got zero calcification, you can rest easy. It really can tell you that you have a very low probability of disease. The majority of people who suddenly who die usually don't have positive stress tests. The reason that they die is that they have a slowly developing limiting plaque that ultimately gets occluded. So this is a way to kind of diagnose it before you have symptoms. Who should have these tests? Low risk, which are men over 45 and women over 55, or men who are higher risk who in age 35 or women age greater than 45. And what are those higher risks? Again, diabetes, and that's really making sure that you are not diabetic. High blood pressure, again, blood pressure is greater than 135/85. Any history of smoking, high cholesterol, or family history of heart disease. Now, this gets to my own personal pet peeve, which is lung cancer. Early diagnosis, great cure, great treatment, and I think it's diagnosed, and the mortality is pretty low. Most people do chest x-rays. Well, if you look here, randomization, if you get a low-dose CT after 3 years, you find diagnosis of lung cancer half the time versus 1/3 of the time with a routine chest X-ray. And the death from lung cancer, X-ray, 400 deaths, low-dose CT, 300. So really important, minimal radiation exposure, a lot of information. How does tobacco affect prostate cancer? It accelerates your risk for hormone resistance. So reduces your chances of tolerating treatment and having positive results. And usually patients who smoke have more advanced disease at diagnosis and higher relapse even after treatment. So the next big thing is fitness, which is what Dr. Schultz pummels into all of us. And fitness is as dangerous as smoking, diabetes, hypertension, and high cholesterol. This is a great slide. 10-year survival, normal people over age 60. If you work out greater than 3 times a week, 10-year survival, 90%. If you work out maybe twice a week, 75%. And if you're kind of a couch potato down here, 60%. So with activity, you really have a good prognosis, good outcome. Also, dementia, our greatest fear, quality of life, losing our independence. Exercise greater than 3 times a week versus less than 3 times a week can make a huge difference in our quality of life. So, fitness not only reduces cardiovascular death, cancer, prostate cancer deaths, and how well we tolerate treatment. Fitness reduces depression, and importantly, when you exercise and you break a sweat, your body produces something called an endorphin, which is our own body's natural morphine. So you see these people outside running and exercising compulsively. That's because they get that feedback, that positive feedback. So if you have exercise and you don't feel so great afterwards, keep with it. Work harder. Gradually increase it, because ultimately it will help. Osteoporosis, which is a huge factor in men, which we definitely don't talk about. Men should be screened after age 60. The screening is a little different than women. Most women get a DEXA scan. We usually recommend a QCT scan, which is a quick CT scan to look for osteoporosis in the spine. More common than you realize. And ultimately also fitness reduces fatigue. What does fitness do for prostate cancer? Well, men who exercise more than 3 hours a week had a 70% decrease in high-grade advanced cancer. And those who exercise more than 3 hours also had a 61% lower risk of death. So, if you exercise while you're on androgen blockade, after 12 weeks, men compared to a control group had maintenance of muscle mass. 42% greater chest muscles, 60% greater strength in their legs. So, what are the other causes of lassitude and fatigue? Deficiency of vitamin D. Vitamin D right now is very controversial. There's a question of how this interacts with vascular disease, how it interacts with cancer. Do we go high levels? Do we stay at low levels? The New England Journal of Medicine last year came out with an article. And they found that in certain cancers, vitamin D levels were very high, such as pancreatic cancers. They weren't sure what the exact correlation was, but their recommendations were that you keep your vitamin D levels in the low normal range, between 30 and 50. Thyroid, also kind of a newer thought with this disease. The thyroid is the big kahuna. It runs the show. You can't live without it. It affects your catabolism, how you build bone and muscle, affects your metabolism, how you burn, break things down. It has a symptomatology of over 100 clinical findings. Thyroid is, and I want you to also look at your labs when you get home, the TSH. That TSH value normally is between 0.5 and 5.5. Well, the American Thyroid Association wants that TSH between 1 and 3. So take a look at your labs and see where you're at. If your TSH is high, it means your thyroid is low. If it's greater than 3, start checking it, and checking it every 6 months. Vitamin D, vitamin B12. Affects our oxygen carrying capacity, affects our nerves. This also needs to be high normal. Normal is usually between 200 and 900. We like this higher. We like this around 900 to 1,000. Alcohol definitely affects this level. And then finally, testosterone. When you get your testosterone paperwork from our office as well, it's kind of hard to read. There's an FAI, there's a SHBG, and there's total testosterone. What do you look at? Well, FAI is free androgen index. It's actually the free, more active form of testosterone. That should be between 8 and 20, and I think that's a much more accurate determination of your total testosterone. SHBG is the protein that binds it. When it's elevated, your estrogen levels may be high. And total testosterone, again, is total of active and inactive testosterone. So a good marker, but not as good as the FAI. Depression. This one is an interesting one. Many people feel depressed, and I feel depression is an emotional manifestation, oftentimes of a physical ailment. If you're feeling depressed, you're not sure, get an exam, get some labs, check it out. Most of us blame ourselves, especially men, I think, have a tendency to feel guilty about it, but I think it's something to investigate, something to look at. And then my biggest thing, sleep apnea, underdiagnosed. Sleep apnea, most men I ask, we have some findings and we think maybe you might have some sleep apnea. And the first answer is, no, doctor, I feel fine, I sleep fine. Well, sleep apnea patients will feel that they sleep fine, but what actually happens is during sleep your oxygen levels drop. And which organs are affected by oxygen first? Your heart and your brain. Sleep apnea causes early dementia and increases your risk for sudden death 8 times, as well as sudden cardiac arrest. How can you know if you have it? Number 1, does your wife sleep in the other room? Are you a heavy snorer? Number 2, do you wake up with a headache or a dry mouth? Do you ever wake up yourself when you're by your snoring? Check your blood pressure in the morning and check it at night. If your blood pressure is elevated in the morning, that may be a sign. If you fall asleep in the afternoon while you're reading a book, driving a car, watching a movie, again, maybe another sign. And finally, if you are on more than 2 blood pressure medications, and it may still be hard to control your blood pressure, think sleep apnea. And by the way, the treatment regimens right now are great. The machines are very small, quiet. You can travel with them. So if that's an issue, ask your primary care doctor. So, annual physical exam. If your doctor doesn't know what color underwear you're wearing that day, you didn't get a physical exam. If you didn't take your jacket off, you didn't take your socks off, you didn't get a physical exam. You need to really be well looked at, including lab tests, urine tests, which can also tell us if you have kidney stones, diabetes, kidney disease, autoimmune disorders. You should get updated on your vaccines. And again, your exam should include pulse, blood pressure, eye pressure, glaucoma, which is also seen with a lot of diabetes. Get a complete skin check, and obviously the DRE, the rectal exam. Scans, men, greater than 60 should have a bone density or a QCT every 2 years. Cardiac calcium score every 5 years, and also that's dependent upon what your initial CT score is, calcium score is. And finally, colonoscopy, which I think this is not necessarily accurate, every 10 years. This is the hardest thing for me to get people to do. And I think what's important to know is, number 1, colon cancer deaths have dropped. A colonoscopy, the worst part of it is the day before when you have to poop, stay home, and drink a lot of water. The actual test itself, you're asleep. What happens? Doctor goes in, finds a polyp. 2/3 of the time they find a polyp. 2/3 of those polyps are precancerous. He takes it out, you're done. No colon cancer. So, Colon cancer, pooping the day before. That's neat. The other thing is virtual colonoscopy. What about that? Well, virtual colonoscopy, you still have to do the prep the day before. They don't sedate you. They put air in your colon. And then if they find a polyp, you have to go back and get the real colonoscopy. So not really perfected yet. Hopefully it will be, but not yet. And also, when you get your colonoscopy, ask for an endoscopy. Have them look in your stomach as well. Barrett's esophagitis is a precancerous disease of the stomach. Many of us don't know we have it. It's an extra 5 minutes. You're asleep anyway. No risk for perforation. Simple. So, lab test with an annual physical exam. CBC, complete blood count. Anemia, white cell count, platelets. Hepatic, liver, screening for fatty disease of the liver, alcoholic liver disease, viral diseases. Basic metabolic panel looks at kidney function, electrolyte dysfunction, which can also sometimes tell us if there's some lung disease. Urinalysis, huge. Kidney stones, gout, diabetes, protein loss, thyroid, vitamin B12, vitamin D, lipids, and a PSA. So what are the vaccines we recommend? Flu vaccines annually. That would eliminate about 40,000 deaths a year. There's also Tamiflu, and that's not really used very often. If you have flu-like symptoms within the first 24 to 48 hours, get started on Tamiflu. It's a 5-day, very easy treatment. How they make the flu vaccine is they find out what the most predominant strain is the year before. So it's not always super successful, but worth the advantage to reduce the risk. Pneumonia, pneumovax, every 5 years after age 65 and earlier if you're immunosuppressed. Zostavax, the shingles vaccine, one time after age 60. So if you've had shingles, should you get the Zostavax vaccine? Yes. You're at risk for having shingles again. And the sooner you get it, the better it works. If you get it at age 60 to 69, it's about 85% efficacious. At age 70 to 79, that drops to about 70%. And after age 80, it drops to about 65%. Still good odds, better odds, but better to do it earlier on. And finally, DPT, diphtheria, pertussis, tetanus every 10 years. Pertussis, whooping cough, is making its wonderful comeback over the last few years. So definitely get this updated if you can. This is a funny slide because Dr. Scholes told me I need some pictures. Oh, here. Patient seems reluctant to get his prostate checked. It's kind of a visual, so you kind of have to see it. I don't know if you see that. It's got a vice somewhere. I haven't seen this yet. Might give you some ideas, though. Okay. So summary of preventable diseases. Vascular disease, heart attack, strokes, blood pressure reduction, cholesterol, fitness, blood sugar modification, cardiac scans. Infections, get your vaccines, and cancer. Get a CT of the lung. If you've had any exposure to tobacco, get your colonoscopy. I'll tell you, I wish my grandmother had this talk, was here. Last time I was here in Fullerton was on my way to St. Jude's Hospital. She was my mentor. She raised me. She was what I call an ambidextrous smoker. She could smoke with 2 hands. She ate a lot of fat food and was the coolest woman in the world. So take these to heart. Take care of yourself. It's within your power. I wanted to talk about quality of life because I think the greatest thing about the quality of life is our mental attitude. There's a great patient of ours who's a psychiatrist who once told me, for patients who worry, ask yourself, probability versus possibility. Is it probably going to happen, or is it possibly going to happen? Be cognitively aware of your fears. That's very important. Stress is a big deal. Remember to ask yourself what you can change today. I can work out, I can not smoke, I can maybe not drink so much, I can exercise, and that's the most you can do it, and you've done your work. What can I do to give back? Be selfless. Look outside of yourself. See what you can offer to the world. And finally, especially for you men, You guys have it tough. You internalize. You're tough. It makes it harder for me because you don't complain. How am I going to know? Let us know what's going on inside. It helps. It helps. It releases it. It takes it out. Shared pain is half the pain. Shared joy is double the joy. And finally, the big question and why we care about prostate cancer treatment is our sexuality, our sexual life. That is one of the forefronts of quality of life. So, during total hormone blockade, it's important. Have an erection twice a week. You need it. It's going to be an exercise when you have hormone blockade. When you're off blockade, it's going to be fun again. So make sure you maintain that, because when you come off, you want to be able to really enjoy. For you men, and as a woman I can say this, sexuality, 90% is intimacy. You are great. You're great anyway. And the intimacy is about sharing, talking, looking at each other, listening. I think that as women, we can't read your minds. We can. But we let you think, whatever you want to think, we can read your minds, right? All of you. So share it with us, please, because it makes us nervous and it makes us worried. I wanted to say one thing about all the women, and Russ kind of alluded to it, all the women who support you, who are sitting there right next to you in that office. I am very impressed. You guys are the lovers, the best friends, the nurses, the secretaries. You are the schedulers. You do everything. And you guys have a great partner. So I wish we had a slide about treatment, because one of the big treatments thing here is really love and relationships. And remember to thank that person every day. I know you do, because I see it in the office. And one final word. I've been now with prostate cancer and as a specialist in prostate cancer in the last year and a half. I have met the most amazing men that are courageous, intelligent, emotional, and have shared and given me the privilege of sharing their experiences that enriches my life every day. I get excited to go to work every day because I'm not sure what I'm going to hear, if I want to hear it, but I know it's gonna change me. So I thank all of you. And this is a good time, I guess, to have prostate cancer because we are getting better at diagnosing and we are getting better at treatment and treatment regimens that instill and maintain the quality of your lives. So, that's it. That might have been a little quick. I get nervous, I talk fast.
It doesn't.
Can I have, there you go. It doesn't matter how fast you are, it's the knowledge that you impart. Now I'd like to ask you a question. You all know from my introduction that I was very impressed with Dr. Mark Schultz and Dr. Richard Lamb. You also now know, when I go to their office, why I hope I get Dr. Chang.
Thank you.
If anybody has any questions, could you please come on up? I know she covered a whole lot of material here, but if anybody has any questions, come on up. We'll get you on the microphone and we'll address questions to Dr. Chang. We're not going to let her leave here without a question or two. Come on up, sir.
Uh-oh.
She said, uh-oh.
Thank you. First of all, you look far too young to be a doctor.
I love you. I heart you.
I hope my question's not a bit off your topic. I was recently diagnosed with prostate cancer, and according to Dr. Epstein, I have a 9, and which is high. And they call it high risk. Do you know what high risk is? I can't find a definition of high risk. My doctor can't tell me. Nobody can tell me what high risk means. I have my own definition based on prudence, but I'd like to know what yours is if you have one. Also, they say when you do today when you do radiation therapy, they combine it with hormone therapy for about 6 months. And I just wondered what the purpose of that is and what the hormone therapy accomplishes along with radiation.
Now let me ask you, have you had any scans?
I've had, yeah, I've had all the scans, and it's localized.
Okay.
It hasn't spread according to the scans.
Okay.
And, but it's a high
Okay.
risk. Yeah.
So,
I'm going to give him this.
okay, great, thank you. It's a great question. It involves the grade of cells, the type of cells, how ugly they look on initial biopsy, the amount of cores that were positive of the biopsies, and the percentage of each core. I think what's important to know is that we do know with high-grade disease that treatment and early hormone blockade and starting hormone blockade with radiation or other forms of treatment really extends your 10-year survival. I think that's really important. The other thing for you to know is to make sure that you got a sodium fluoride bone scan, not just a technetium-99 bone scan, because high-risk disease means that there may be a higher chance that there's disease outside the gland. We want to make sure that there really is nothing, and we have very many high-risk patients who do very, very well. So yes, it is good to label, but also I think, and this is a reference to Snuffy Meyer's video that I know you have on your website. I love Dr. Myers, not just because of his name. I think he's an incredible, intelligent man. And it's true. I don't think we really understand the characteristics of each cancer cell. We have a Gleason score, we have some cores, and we have amount of cores and how much it's gone outside of the gland. But every cancer and every patient with prostate cancer is very individualized. And we're learning more and more about the finer characteristics of each tumor and each cell. So, Gleason's 9, for what we are able to diagnose with our modalities now, sound more significant and obviously more aggressive, and our treatment regimen is a little more aggressive. But as far as long-term, with the newer diagnostic imaging and the newer treatment regimens, prognosis could still be very, very good.
What kind of scan was it you mentioned? What kind of bone scan?
That's a sodium fluoride bone scan. It's not a technetium-99 bone scan, and there are only certain places that do it. And I'd encourage you to get it done, because the two scans are like apples and oranges. At the Prostate Cancer Conference, Dr. Dusing from Kansas was talking about the carbon-11 acetate scan and sodium fluoride bone scan versus technetium-99 bone scan. Technetium-99 bone scan will become positive at usually with when the disease is already beyond, I think, a PSA of 20 and fairly extensive. It's not very sensitive, but now with these newer scans, we can find it and find it sooner.
What's the name of that scan again? I didn't understand.
It's called a sodium fluoride.
Sodium fluoride.
Yeah.
Okay. Well, what I'm going to do, and I've decided, is I'm going out to Houston to the Anderson Cancer Center.
Okay.
And I'm going to have a meeting with their cancer board. And I've sent all my documents out there and find out what their evaluation is and what they recommend for treatment.
You should come to our office.
I might.
You should. And I'll tell you what, the other kind of scan is a carbon-11 acetate, which I was talking to Dr. Wiseman about. An exciting scan not covered by the FDA right now, but it's a one-shot scan to look at soft tissue and bone. In non-enlarged lymph nodes, it picks up very small disease. It's about $33,000, but an amazing technology. So come to the office.
Okay, this segued right into something that I wanted to tell you anyway. I'm ready for more questions. Thank you, sir.
Yes, sir.
She said come to her office. Out in the foyer out there, we have these pamphlets that, believe it or not, are put out by the prostate, her group, Dr. Mark Schultz, Dr. Richard Lamb, and Dr. Patricia Chang. So if you want to find out how to go to her office, a little bit about them, these flyers are out there for you. Anybody else? Murray?
Oh no, not Murray. Anybody but Murray.
Dr. Chang, it's been a pleasure. Thank you for coming all this way. I know what a hardship it is getting across town. I was sitting with several folks who were talking, as it turns out, about hormonal deprivation and active surveillance and the side effects that typically accompany it. Is there a way to minimize the most prevalent effects, such as, we talked about malaise and lack of energy, weight gain, as well as increase in memories and so on? Are there various kinds of either prescriptive or supplements that can minimize those kinds of effects?
Great question. As far as prescriptions go, one of the mainstays that I love is something called Provigil, Nuvigil. And what those two medications are is they work on the GABA receptors in the brain. They're not amphetamines, you can take them as needed. They FDA regulated for sleep apnea and narcolepsy, daytime somnolence. And what it does is just kind of keeps you a little more alert. So safe in heart disease, it's a great drug. Those are two really great drugs. Malaise, fatigue, boy, that is a, not only just daytime, but it's important that you rest well at night. What's your sleep like? Do you drink at night? Alcohol, actually, and many patients in our practice, surprisingly, drink more than they probably should for the quality of life. If most alcohol makes you tired, you fall asleep, and then you wake up at 3 a.m. Well, 3 a.m. awakening is classically because of alcohol. And alcohol is a depressant. It actually makes you depressed. So yes, it relaxes you, you feel a little easier, but in the long run, it serves no benefit. Some of the other medications we do use are more of the stimulants, little cardiovascular risks, such as Adderall, Ritalin. You can use those as well, but I think the real key is get moving. You're too tired to exercise, but once you get started, once you start doing a little bit, maintain your muscle mass. Your muscle mass is your metabolism. That keeps you going. Those things are very important. Anxiety and stress increase your hot flashes. Lack of sleep increases your hot flashes. We do have medications that also help with that as well. So routine, regularity, and also keep doing what you love to do. Creativity, enjoy your life, plan things, plan trips, get excited about things. Don't forget to do that. Don't put your life on hold. So, I don't know if that helps.
Dr. Chang, during intermittent hormonal therapy, using Lupron, Casodex, and Advart, and you go on a vacation period of 8-10 months, what are your guidelines for then starting back up? In other words, obviously your PSA is going to go, but do you have levels of PSA when you say, wait before you start the treatment again?
Right. That's a loaded question. As you know, there's some men who are low PSA producers and those men who are high PSA producers. I think what is important, we find out what your nadir is, how low you did go. And from that value, we can use that sort of as a reference to when we're starting to see a trend and see if there's any new disease. Also, as you get off hormone blockade, your testosterone will rise. As your testosterone rises, how much does that PSA change? Does it kind of hold steady? Does it increase a little bit? Or does it jump right up? And all those things are determinants as to whether or not you need to restart hormone blockade as well. And also just screening, imaging, testing to see if there's any other areas of disease that we have to be concerned about. What always, I think, concerns me is that there are patients who have Gleason 6 disease who, down the line, have a recurrence, have a relapse. It's not, I think we still have a lot to learn about the cells themselves and how they function. So I don't know if that answers your question, but there's no absolute number. You know, it is also dependent upon your own values.
So you're basically saying that once you have started hormonal therapy and then gone to negligible and you're off for 8 or 10 months, it's still, you should do screening. In other words, if you get your PSA down to negligible in another 90 or 6 months, should you just keep doing that and not worry about screening?
No, I think, you mean if your levels stay low?
Well, yeah. I mean, if you go from, say, a 0.11 to a 0.32
Right.
to a 0.48,
Right.
and then you start on hormonal therapy, and then you go back down to under, 0.1, and you stay that way for another 5 or 6 months, you go off hormonal therapy.
Mm-hmm.
I mean, are you suggesting that you should still do screening during
No.
that time?
No, I think screening is when you're obviously seeing a trend of
Okay,
Of
it
rising.
doesn't go down. Your PSA doesn't go
right,
down.
and it's not really, it's changing out of range to the change of testosterone. The other marker we look at is at what level your PSA was when we first started the hormone blockade. So that's another little marker.
Thank you.
Thank you.
Well, Doc, I had a question about Abidar. I was
Yes.
at the conference in LA, I guess that was last September, and one of the speakers brought up that Abidar lasts a lot longer than just the one day. And I was taking Abidar daily, and then they said to go to every other day, and then after that maybe only once a week.
Right, great question. Abidart does have a longer half-life. It also works on 2 receptors rather than just one, which is finasteride. So finasteride has a shorter half-life, and Abidart has a longer half-life. So just like cholesterol medicine, for instance, Crestor, long half-life, you can take it 3 days a week and still have some great effects. So is for Abidart. I think if you are worried about the side effects and you want to go on a lower dose, one marker to follow is something called a DHT, dihydrotestosterone. That's what it's blocking. It's blocking testosterone's conversion to DHT, and DHT is the AK-47 of prostate cells.
Right.
So-
I took it daily, my DHT was, I guess, almost non-detectable.
Right.
Went to once every other day, and it went to 2.
Okay, so less than 5, less than 3, less than 5 are kind of the markers that you want to shoot for.
Okay, so you think that jump from undetectable to 2 is acceptable?
Yes.
I might add, ask, do you pay for your Abidart or does your insurance company?
Right, exactly.
Oh, I got a copay.
Okay, that has some bearing on it also with a lot of
Yes.
people. Okay, is that, okay.
Hello, doctor.
Hi.
I'm sorry. I had surgery in January of 11, and I was at a Gleason of 6, and after the surgery, they raised it to 9. And was told that after a few months it would be good to probably start radiation therapy along with hormone therapy after I healed, which I did this last June. And I'm at 0.1 now.
0.1.
Mm-hmm. But they tell me I'm going to be on the blockers for maybe 2 to 3 years.
Right.
My follow-up appointment is next month, in a few weeks. So I've talked with other people since then who have been on the hormone. I'm on the Vicalitamide
Biclidamide, Casodex,
and on the
Lupron.
Lupron. And I've other prostate cancer friend that I've met and talked to. They were only on the hormone blockers for maybe 6 months, or a short time.
Right,
I've never heard of anyone else being,
for that long.
yeah, for that long of a
Right.
period.
That is actually standard of care.
Is it?
You really should be on for at least 2 years. And obviously it depends on how well you're tolerating it, you know, how much you can tolerate, how much fatigue, all that stuff. But the longer, again, 2 years, 18 months to 24 months is really for your best.
I don't seem to be having too many side effects. I mean,
Oh,
they're
that's great.
small. They're small.
That's great. I love hearing that because many people get very scared. And I have many men who do extremely well. Minimal hot flashes, still working out, feeling great. And if you're one of those lucky people, that's awesome.
I'm exercising. I have gained a little weight, but I'm trying to.
That's awesome. That's great. That's great. Good for you.
I'd like to do a follow-up question on that, if you don't mind, Joe. You know, a lot of people, a lot of doctors say, well, 1 year on triple hormone blockade or whatever is pretty traditional, and yet he brought up an instance where you said it's traditional or standard of care to go 2 years. Now, what's the criteria between 1 year and 2 years on hormone blockade?
If you've got a high grade Leeson score, I don't know if there's any extracapsular extension. There may be, I wonder if because they radiated prostate bed after surgery. Do you know if there's any disease outside the gland?
Yes, they found some on my bladder.
Okay.
And on none in my lymph nodes that they removed. And I had a bone scan.
In case you can't hear, you had some on the bladder, none in the lymph nodes, and what was some on the liver?
Tubular.
Is seminal vesicle?
Yeah.
Seminal vesicle involvement. So he did have extracapsular involvement. So that's another
important
reason, yeah.
Right,
Okay.
exactly.
Hi, Doctor.
Hi.
Thanks for coming out. I have a question regarding one of the side effects of triple hormonal blockade, and that would be a cognitive decline, which would affect your memory
Right.
and perhaps other things, and you would know better than I, but I recently received a flyer from Life Extension. Are you familiar with that group?
I am, but I haven't really seen any of their.
Because they just came out with a product that's called Cognitex, and it's supposed to help with any of these problems with memory and cognitive ability. So I was wondering if that would be helpful.
I think that if you have a product that is going to give you an answer for such a disease or a complaint that has multiple etiologies, causes, although you're on hormone blockade and it can affect your cognitive ability, I think that it starts with first screening for the more common things that cause cognitive changes. Get your blood tests, get some imaging, get some neuropsych testing. Those things can, if you're worried about memory. Sure, you can try something, see if it helps, but for me, I would rather find a diagnosis and make sure nothing else is going on before I jump to a product.
Before you would jump to a product such as that?
Probably. I would definitely get checked, you know, by your internist or your primary care doctor to make sure nothing else is going on.
I see.
Yeah.
Not quite as simple then as just...
Not at all. Not at all. You know, I think a lot of people tend to sort of group their symptoms and relate it to testosterone deficiency or hormone blockade. If you ask many patients who are testosterone deficient and they go on testosterone therapy and they come back, testosterone levels are much better, and you say, hey, are you feeling better? They'll usually say, maybe. So yes, there are people it can help. It's not the gold answer. I think there are other things that you definitely have to look at.
Well, it's hard to separate the effects of aging and the effects of the drugs.
Right. But find out what else there is or can be, and many of those things can be changed.
I guess there's not too much study then in this area.
I don't think you can link the two. I don't think you can just treat. If that was the case, then we would put that in our drinking water. You know,
Thank you.
Oh no, not Frankie. Not Frankie.
I just want to first make a personal comment, personal experience, because I see Dr. Chang along with Dr. Schultz and Dr. Lamb, and she gives a hell of a digital rectal, so if you...
I'm double jointed.
The other thing I wanted to ask you, Snuffy Myers, one of his letters talked about red wine. So I've been trying to do it medicinally, you know, because, you know, just a glass with dinner. Now, I could do without it, honestly, but because you talked about the sleeping thing, I get up because I have to go to the bathroom, you know, probably 3 times a night. But do you think the red wine has the benefits that outweigh some of the negative stuff that you were talking about, and is it okay?
What is,
you know, I'm on triple hormone blockade. This is what the triple hormone blockade does, by the way.
Look at this is triple hormone blockade, a mensch right here.
Since 1996.
Yes.
With a PSA of 239 and a Gleason of 4+4 and a 5+3. So you know, it works. I mean, there's a lot of walking involved though too, and you know, whatever exercise I can squeeze in. But so you know, what do you think?
What were his final thoughts about the benefits of alcohol?
I don't know, he just said, you know, red wine, the benefits of.
Oh, okay, gotcha. Has it changed your sleep pattern?
I have no idea because
No change?
The problem with getting up to go to the bathroom probably overrides everything else.
Right. That's probably it. So it doesn't sound like maybe that's affecting you so much.
Mm-hmm.
So don't throw away the cab. Not yet.
Yeah.
I mean, I think if you enjoy it and it helps a little bit, it's moderation. It's moderation on things.
And I never really asked this before, but the 4+4 I had, and then the 5+3 on the Gleason scores. If one was to just look at the 5, which is really ominous, would that be the leading indicator of the worst case scenario as far as Gleason is concerned? If there's even a little bit of that 5 in there, it's the thing that's going to possibly dictate, you know, where you're going to go with this disease?
Oh, I wish that we could look at that and give you an absolute value. I don't think so. I mean, the first number, as you all know, you have a core, a certain percentage of that is positive. Of that positive core, how much of that is 3, 4, or 5, and how much is the other one, 3, 4, or 5? The majority of that core, if you have maybe 60% of a 5, then you're a 5+3. If you have 60% of a 3, then you're 3+5. So the sequence of the numbers is very important to kind of look at. Also, is your 5+3 a 60% 5 or a 90% 5? So also that really matters in looking at diseases.
Yeah, and I also want to just add something when you said, you know, don't worry. I worried a lot at the beginning, and I did all my analysis because I also have more degrees than a thermometer. And I concluded I was only going to live 6 months. I was told I would have about 2 years, but there's a higher power and we're in church, so there's something else working that, you know, you just have to rely on sometimes.
Right. I think that's a good point. I find more exceptions to the rule than the rule. Please don't look at statistics. Let them be a guideline for you. But most of the time, they're not worth very much. Everybody's different. So, yeah, thank you.
Doctor, thank you very much for your presentation. It's helped so many of us. I hope I haven't missed my question I'm going to ask you. You've already answered, but I just came off of 13 months of hormone blockade, and I want to get back into my sex life,
Yes.
And I was wondering, is it intelligent to add testosterone to my body? Like I could get testosterone shots or what? Okay.
Right. And so how long have you been off hormone blockade now?
I've been off maybe a month.
A month,
Yeah.
okay, so you barely.
Yeah, I don't know anything, yeah.
I wouldn't, testosterone, it plays with fire, obviously, we know that, that's what we're fighting. So, I would be patient, number one. You've just gotten off of it, so give it some time. Exercise. Don't put pressure on yourself either. Don't put pressure on yourself to perform. Just kind of gradually ease into things. You don't know what's going to happen. How a man's testosterone recovers. I have a 90-year-old whose testosterone jumps to 900 after a month, and then I have men who takes months and months.
Right.
So,
all right, I'll follow your advice. One thing, I was never advised in the 13 months to stimulate my penis.
I know.
And that's sort of a shock to me that would have been better if I would have done that.
It is such an important part, and I wish we would emphasize that more and more. Either it's daily Cialis, daily medication, or twice a week. I don't know if you went to the prostate conference last year either. Get the disc. I'm not trying to market it. Get the disc. You'll learn a lot. But Dr. Auerbach, urologist, I heard his talk, and he was talking about erectile function. He recommends something called penile yoga, which is using an inexpensive vacuum pump and having an erection, holding it for a minute, deflating, hold it for a minute, 10 times in the morning, 10 times at night. The tissue needs blood flow. And, many of our organs are like starfish. They come back. We don't need a lot, but they regenerate. We know we regenerate lung tissue. We know we regenerate heart tissue. As best you can, without too much pressure.
Thank you.
Yeah.
I hope it's informative, but I had prostate cancer, and I had semen implants, brachytherapy, and my last PSA is 0.02, which I'm quite pleased with. In the meantime, I have been looking at testosterone included in my regimen. And just today, I also subscribe to a wellness center by Dr. Whitaker in Newport Beach. He's in here advocating the use of testosterone.
Testosterone?
Testosterone.
Uh-huh.
And that's what I've done. My current urologist has put me on it, but he said the levels got so high, he's taken me off of it for a month. Then it subsided, I guess. What is your opinion of this?
Did you feel better?
Yes.
You feel better? Okay.
And perform better.
I'm sorry?
And perform better.
I think, again, it's also individualized. You've got to look at how aggressive your disease is when you first started. If you are on testosterone, we do put men on testosterone, but you have to be monitored. You have to have someone who really knows what they're doing and keep a close eye on you. And obviously, we don't need high levels. So that's good. Your PSA has remained low on testosterone supplementation. That's great. We have many men who have that as well. So
the combination seems to work.
It can. You have to test drive it and see how it works for you, but remembering that you're also, running risks.
Okay. Thank you.
Thanks.
Dr. Chang, thank you very much for being here. I'd like to ask a question if these hormone treatments can be part of the problem, not so much from the prostate cancer itself, but from the heart attacks, from the blood pressure, the cholesterol, all of those things, if that can increase those particular things in a patient.
I do not think there's a direct correlation. I think they're kind of branches off the same tree, I guess. If you're on hormone blockade, Yes, there is some weight gain, but because of some of those issues, which you can counterbalance with your own health maintenance, your diet, your exercise, I wouldn't stop it because you have a high vascular risk. I would just really work on your vascular disease. I don't think we have many patients who we haven't treated with hormone blockade because they have underlying vascular disease.
Thank you, doctor. It's really amazing how much you know. But we know how to monitor the PSA and so forth by testing, but I don't hear much about the Gleason score. Once initially diagnosed at 6, whatever it is, then that's it. We don't hear any upgrades or downgrades or whatever. Your comments, please?
Well, Gleason score is the amount of disease that was diagnosed from either biopsy or pathology from actual prostatectomy. We use it as kind of a marker, if you will, of how aggressive the disease is and how aggressive our treatment should be. Now again, Snuffy-Myers talks about how there are so many different types of prostate cancer. We don't have any other marker of characteristic of cells. It's the only way we can kind of determine whether your risks are low or the risks are high. We do know with the lower Gleason score that your prognostic outcome is actually much better than those with higher Gleason score. But once that's determined, again, we use that as treatment. Now, if you've had a rebiopsy, so you have a start Gleason score, an additional Gleason score would be if you have a rebiopsy. We do rebiopsy and then upgrade or downgrade our Gleason scores. I don't know if that answers your question.
No, that answers my question very good. I would think that would be an important parameter, like 5 years later or X amount of years later, to see how the Gleason score has changed.
Oh, has it changed?
Correct.
Well, right. It changes if you rebiopsy. If you've had a prostatectomy, it obviously doesn't change. So.
Thank you very much.
Thank you. Murray, I think you already asked a question.
Just one more. Obviously, everybody has read about the controversy of PSA screening in the local press. There's a recent study showing that, from Europe, showing that there's a significant reduction in death rate for those in the group at which the screening was applied, and so that counter to what the uproar seems to be about. And my question is, does your organization have a stand or an opinion yet as whether, because it comes up all the time with our newly diagnosed,
right?
Should men be screened for PSA at appropriate age level, say 50, or should it be postponed or left to the doctor's suggestion, etc.?
I hate that question because right now we're changing all our guidelines. Less mammograms, less pap smears. It's a simplification of a very complex problem. It is a tool. It is a tool that requires further research, it's one number in a number of other issues such as ultrasound, physical exam. It absolutely should be part of a puzzle. It should be a part of a piece of a puzzle, but do you use that number to then suddenly decide on therapy or change anything? No. And should we screen for them? Yes. And I don't know if the reason we're changing our guidelines is because of, and here I go on my political bandwagon, not really politics, but certain guidelines and FDA regulations, a lot of those you wonder where they come from, because I just can't see if less screening or getting more information hurts you. It can only help you, I think. It's a blood test.
That's what we all think.
Absolutely. Keep saying it.
Okay, I think we've beat her to death up here. You've all, well, I don't know whether you've all been here for Dr. Schultz and Dr. Lamb when they've given their presentations. Now you know why I'm very impressed with our Catwoman. saying thank you, you know how much we pay her to come here. Because we don't have a big budget. But one of the things that we can do, there's two things in the world, time equals money. We can save her some time because we're going to give her this cup for her coffee that fits in the cup holder so she doesn't spill it. So she doesn't have to worry about getting her coffee at home. She can drink it in the car on the way to work. Thank you very much, Dr. Chang.
Thank you, Russ. Thank you.
One more quick announcement that I would like to have to wrap things up a little bit. Prostate Forum of Orange County has been working for a considerable period of time with a professional video on incontinence. It's a Hollywood-style video with the producers and directors and all that stuff. And it's supposed to be coming out next month. John Terrio, would you stand please? John Terrio has been working on this for at least 6 months. Lou Pfeffer was working on it, and then he was working with John. And is it going to be ready next month?
It should be ready. The name of it is going to be How to Live Your Daily Life with Incontinence.
How to live your daily life with incontinence is what he said. And the reason, and John is one of the stars in it because he had a terrible mishap when they did a radical prostatectomy on him, and he's been totally incontinent ever since. He doesn't mind me telling this because he goes around and he tells people how to deal with incontinence and how to dress, how to, everything there is about it. And when you get his information, you learn that you can live with this malady. So, how to travel, an important part.
Swiss Alps, in France, and in Canada.
Did you say ski?
No, I have an accent.
He said how to go to the Swiss Alps or Switzerland or something. I thought he said ski. He says, no, he says he has an accent. Okay. That's all we have to offer, folks. It's now up to you to converse with each other. If anybody would like to say thank you to Dr. Chang personally, but please be courteous and let her get a chance to get out because, like I say, she does have to go to work tomorrow.